or that earth-shaking. Elevated blood pressure, I think, is one of them. Obviously, you have to treat elevated blood pressure in older people just like you do in younger people. It does have implications for cardiovascular disease. The one thing you do have to remember when you're treating elevated blood pressure in older people is be careful on what medications you use and how rapidly you dose. That's probably a finer point. And Dr. Latasti will bring a little bit more about some general principles to think about dosing, but it's almost always 1/2 to 1/4 of a starting dose for somebody else. And you watch it for longer to be sure that you don't create dysfunction. So treating is careful. And the other part about dosing and treating people with high blood pressure is you have to be careful about how low you lower the blood pressure in those individuals. You may not want to take it all the way to the bottom. And do y'all remember from your hypertension guidelines, there was what was the age at which the goal of treatment was different? Everybody was less than 140 or less than 90, except for people over what age? 60. It was 60. That's the J and C 8. And those were less than 150 over less than 90. Remember that? So they're giving a little bit more give to that. And the other issue with treating blood pressure in older people is you have to really be careful that you don't aggravate or add to orthostatic changes because they are prone to them anyway, and then the medications can aggravate that. And what happens if orthostasis is out of control in an older person? Fall. And fall is the beginning of the cascade of events that can lead to their demise. So you really, really have to pay attention to it. It's almost like blowing dust in your face from the starting dose. Just a little bit. I mean, you always think it's not very much. Well, just wait and see. Okay, just trust it and let time go by. So elevated blood pressure has to be responded to, but more carefully. Now, postural changes, we just talked about those. They can be asymptomatic. People may have problems with orthostasis and not really feel so lightheaded or dizzy when they get up. They just go over. It's kind of weird, in older people. So they almost can't help you sometimes with how their body has changed on them. And it sneaks up on them as much as it sneaks up on us, what's going on. Obviously, age is part of it. BD conditions are part of it. Postural changes, drugs are a big part of it, a big, big part of it. It's more common after they eat. Okay, so they'll go into a dining area to eat if they're in assisted living or a nursing home, or even at their own home if they're still independent. They eat. You're almost always sitting at a table and you get up. After you eat, what does your stomach do? Where does blood flow go after you eat it? Goes to your stomach. Okay, that rerouting of enough blood flow just for digestion may be enough to tip the balance of postural changes so they can fall. So you have to be careful with that. And they do have the postural changes are aggravated by volume depletion. So if it's a really hot day and they're dehydrated and they're already orthostatic anyway, that makes it worse. But it can happen even if they're completely hydrated. It's part of their vascular response with position change. It doesn't work as well. It just doesn't respond as quickly or as powerfully. Irregular pulse, you'll find a lot of irregular pulses in older people and a lot of extra beats, a lot of odd things, bradycardias, tachycardias, extra beats, PVCs. Most of the time they are non-consequential, but they will still be evaluated. If you have somebody with notable rhythm disturbances, you might still evaluate it, but it's common just in a one-time, I'm going to listen to you, I'm going to take a pulse, I'm going to feel your pulse. You might feel some skips and think, that is just a regular, strong rhythm and rate. It's not that unusual to find that. And it might throw you when you first see a patient, but look back at old records, look at old EKGs, you'll see a pop or two of a PVC here and there that gives you that sense. Tachypnea, is interesting. You can check respirations. It's more important in older people to just get baseline and continue to follow it, because so many of the changes in disease over time are subtle, and if you don't have a good documented baseline for all of their vital functions, it's hard to know when you have a subtle change that might mean something. They won't tell you a lot of things going on, but you just look at the numbers, and their body is responding in a way that is not quite the way they usually are. Okay. And then weight changes, we talked about that the other day, that weight does change up to about that. You gain weight until about 65, then you start to lose weight, and muscle mass gets replaced with fat mass as the person ages over time. Okay, but weight loss still needs to be looked at in individuals anyway. You're still going to be weighing people routinely. They give a little guideline here in the handouts. Losses in excess of 5% of usual body weight over 12 months or less should prompt search of underlying disease. Could be a cancer, could be some gastrointestinal problem, could be depression. I mean, it could be a lot of things. So even though weight loss is not unusual in older people, more rapid weight loss in a defined period of time might indicate some changes going on. That's a problem. So again, it's just maintenance. Okay. General appearance, a lot of things. Poor personal grooming and hygiene, always think depression. Because once people don't care about the way they look, that says something about their overall cognitive state a lot of times. So that it is important to look at it. Now sometimes it might just be, I can't really do makeup, my hands are too arthritic, I can't really get up in front of a mirror and look. So sometimes people's appearance goes down because of other functional disabilities, but sometimes it goes down because they have begun not to care. And then that is something that can be addressed as well. Okay, slow thought processes in speech. Okay, that is not unusual for older people. Older people will not do like that. You know, y'all are at your age where you're pretty much at your peak mentally, and your brains work very fast, and your speech is very fast. It all just comes rapidly. And with older people, it doesn't go as fast. It doesn't mean that they're not thinking well, or that they're trying to dog you or just take up a lot of time. They don't process as rapidly as you do. And so that's, again, why patience is real important when you're working with older people in particular. It can be the signs of other diseases. I mean, obviously, when it's a notable change, it could be, they give example, depression, Parkinson, any number. It could be a stroke. Who knows? A very light stroke. Ulcerations can be commonly seen. A lot of are vascular in origin. They're also neuropathic in origin. They're often vascular and neuropathic. You know, if you've ever looked at older people's legs, you know, just look around, you will see sores beginning, you will see swellings, things that you just don't see all the time. Those are not unusual in older people, but again, they can progress to problems. It can become a decubitus ulcer or something, and then that could, of course, create sepsis, which could create death, you know, could lead to death in that person. Okay. They do make a comment, and this is true, pressure ulcers are common, but they're easily overlooked. That's why a lot of times what happens in older people, it happens all the time, and you ask yourself, how does it happen? How do people get pressure ulcers? It's because people don't examine their body fully every time that they are seen by a healthcare provider. And why do you think they don't do that every time? How can you go visit after visit after visit, and then all of a sudden you see this big ulcer, like, and everybody criticizes, well, they must be sorry care providers. Why do you think that happens with older people? Time is one, and with time and their immobility. Sometimes it's just a lot of aggravation or effort to get a person disrobed, to get them up, to look. And if you're pressed for time, you might just ask, is any changes on your body anything you see? They might say no, but the truth is they can't see and don't feel anything. So you kind of need to look. So it's a big standard of care in nursing homes to move people, to roll people. And in ambulatory care practice with older people, it's still good to do examinations fairly periodically, even with people who are at home and still fairly mobile, because that might be their big movement moment to get ready and to go to their healthcare provider. But then when they're home, they're sitting all day, every day in a location because it hurts too much to go walking around and doing stuff. And so they're just as prone to sores as anybody else. So you do want to kind of look at it. And you know, even for that, all that being said, it will still probably happen to you. You'll probably have a patient develop an ulceration, you'll feel bad, and it will just be a consequence of the culmination of all those events. Time, patient might say, I'm okay, I don't want to do that. You don't want to fight with them. You know, it's that kind of thing. Another, page 21, the ears. Older people do have diminished high-frequency hearing loss. That is a very common thing. And you know, you don't know you've lost it necessarily. People don't really understand how well their hearing is until it's actually assessed by somebody. How many of you have known older people who say you speak too softly or you mumble or I don't know, you're not talking clear? And they get mad at you. Okay? And then they'll go, you need to have your hearing checked. You need to talk, you're always mumbling over there. And nobody's mumbling, and then they do a hearing thing, and they have had high frequency hearing loss. So they're hearing about, you know, 2/3 of what you say. You know, it's kind of garbled. So it's like when you're in your world, you're right, everybody else is messing up until you kind of flip it back in there. But definitely, if people can't hear whispering even close to the ear, is a good time to evaluate further. It is often helpful to ask the surrogate caregivers, the others in the home, do you believe that there's any issue with hearing? That's always a fight. Well, y'all, it'll be a little bit of a fight, but it's worth asking the question because often the patient won't be the best witness to what's really going on with their hearing in their home. Okay. Eyes. Obviously, you got to do eye exams often. Correction of lenses, it changes as a person gets older. When y'all had AGET, y'all talk a little about correction over time. It's possible as a person gets older that their vision will improve to the place where they don't need glasses anymore. They also have a large number of other issues that can happen. Cataracts are not that uncommon. They impair vision. So you'll always want to be doing a check on it. They make a note here that hemianopsia can also be can be missed unless you do direct testing, because you get a little stroke and a little loss of vision and not quite know, because they'll still be functional enough without direct specific testing. Okay. Mouth, it's very important to consider the mouth. And you know, often healthcare providers don't deal with the mouth that much because it's kind of like that's a dental area. And I know that may sound terrible and we don't pay as much attention, especially if you have limited focused evaluation, you may not look at mouth. But in old people, it's important. A lot of times they'll have dentures that don't fit and they won't wear dentures and they won't go to get them done and they're afraid it'll cost too much money. They don't have dental insurance, so it kind of falls apart. Or there will be infected teeth because they haven't been to a dentist, but they don't have pain with that and you can't tell. And then you look and go, yikes, you know, it becomes a major problem. And then they won't eat, okay? So dental problems unattended to actually can lead to malnutrition because they just simply can't eat. They may not be able to go in the kitchen and get food because of mobility issues, but then if they have problems with their teeth or there's a little bit of pain to them, then they may do even less. Becomes a problem. Okay. Skin, you just finished skin. You went over actinic keratoses, basal cell carcinomas. You do have to look for those. They are very common in older people. Just in fact, so many you can't believe how many AKs people will have on their skin. And you do have to pay attention for basal cell carcinoma because again, it's something as a person gets older and their vision's not good and they can't move around and look at themselves. They may not see things. So you do want to be observant for that. Chest. Interestingly, crackles are heard and can be heard with no pulmonary disease or heart failure. Okay, atelectasis is real common. If you looked at pulmonary changes in those physiologic changes that happen, atelectasis can happen in older people just as a matter of routine, and it may not be associated with a pathology. But if you have enough of it, you're going to end up with some health-related problems and complaints. And obviously respiration won't be that effective in those individuals. Okay. Cardiovascular systolic murmurs, common and usually benign. So you can hear a systolic murmur in them. You'll need to do other evaluation to figure out whether it's something new and difficult. Carotid bruits always need further evaluation, and you will find quite a few carotid bruits in older people, whether they're managed well or not, or anybody's worried about them is another issue, but you do need to pay attention to it because that can be the herald sign for a stroke or something down the road. Vascular bruits are also common. Femoral can happen with symptomatic peripheral vascular disease. Just think, you've got older people with vasculature that's been around for a long time under high stress conditions of high blood pressure, so all the places where the bifurcations are and thickening can take place, that's going to be your greatest, you'll have your greatest source of findings when you're doing those vascular exams in older people. Okay, diminished distal pulses, that's pretty common. In fact, very mostly common. Let's see here. Abdomen. How many of y'all has anybody here come across an abdominal aortic aneurysm yet? Anybody? It will be interesting when you do come across one, because you might come across pulsatile. You might, if an older person's lost a lot of weight, you can see things better, and you can hear things better, and so you may actually find that within them with that pulsation. Of course, you have to go do the further evaluation for whether or not it is what you think it might be, and whether it's something that can rupture, because that can be the end of the line too. And the thing is when you get into older people and you find these difficulties, you will enter into discussions with them also about what you want to do with it. I knew a man who was in his late 80s, and he was discovered with an abdominal aortic aneurysm, and surgery was certainly something that could be done, but he was high risk for the surgery. And it was a big discussion whether to do anything with it or not, just let it happen and that's it, whenever it would happen, or to actually go in. And in the end, they decided to go in, and he died in surgery. But he called the ballgame. He knew the risk and benefit, and he said he's had a good life, and it was really a big decision in that family to do that. Okay. Genitourinary, a lot of atrophy changes over time. Testicular atrophy is normal. Vaginal atrophy is normal, leading to a lot of things. You can get dyspareunia for those patients who will remain sexually active, dysuria. And it depends on what individuals want to do. Some older people decide not to be sexually active, and then the atrophic changes are less problematic. And for older people who do want to remain sexually active, then dystrophic changes need to be addressed with some form of lubrication or whatever. So again, it's a matter of preferences and discussing with the patient. Okay. And we're not going to worry about pelvic prolapse. It's not that uncommon. Extremities. Periarticular pain is interesting. It doesn't always mean it's joint related. There are a number of pains in older people, quite a few, and the advice is always pursue what it might be caused from, not to make an assumption. You know, it hurts in my hip. Okay, is that just a hip joint that's arthritic, or is there something else happening that needs to be looked at? So the advice and the best practice in geriatric patients is to follow through on sources of pain, because they may not be what you just ascribe it to. It may be something else. So they do need to be looked at. Limited range of motion, very common in older people. You may have to get therapists involved once you figured out what's wrong and what can be done, what can be gained by treatments. Edema, very common, usually venous insufficiency, usually a touch of heart failure, and you see those swellings. A lot of people don't like their swollen ankles. Women in particular don't like swollen ankles because it's a cosmetic problem, so it's like, what do you wear? Women with really bad legs and they're older almost always want to wear pants. They don't want to wear dresses because they don't want to be seen, or they'll wear stockings or things to hide it. So it becomes a problem. But it's more than cosmetic, because if you have significant venous insufficiency and swelling, it can become the basis of ulceration and skin breakdown. Did y'all see that when y'all did derm? Did Jessamine come in and talk about stasis, ulcers, and things from venous insufficiency? They can be pretty dramatic and also very difficult to treat. Many places need to be with wound healing and a rigorous program to keep that skin from breaking down further. Because again, once you have breakdown, you then run the risk of other complications, infection. You may even move to a place of needing amputation to get a gangrenous area going on in a lower extremity, and that's not a good outcome. And then neurologic, abnormal mental status always needs to be assessed in older people because you never know. Depression, delirium, dementia, stroke, and you will be looking at this much more closely this afternoon, but that's always important. And again, like I said yesterday, it's important to maintain regular contact with a person so you can see subtle changes. Children who abandon parents, don't help them that much because they're the ones who kind of know their behavior and their personalities the most, and others may not know them. So when you lose contact, or you may be contacting once every 2 or 3 months, you might go, well, they're really different this time. Maybe that's insidious, maybe that's abrupt. The family is less helpful when that takes place. Okay. And as your table indicates, it's a bunch of things. It can be drugs, it can be infection. Very often you have to look at medications. They are pervasive and in older people quite problematic and difficult to tease out unless you really pay attention to baseline, start something, now what do I see? Okay, as a new change. Almost always one of your first rule-out questions when somebody is having a new problem, has anything new been done? Have you started a new medication? It's just one of the first questions to always ask. Okay. All right, we're not going to worry too much about weakness because you do have, there's weakness in older people in general, loss of muscle mass, loss of mobility. New weakness, new onset weakness has to be evaluated for the potential sources of that. Okay, let's look at, we're going to move on because those other parameters we'll look at here a little bit later. Laboratory assessment, on the next page on 23, you have the parameters that are usually unchanged are listed. H&H, WBC, platelet count, electrolytes, usually okay, BUN, liver function test, free thyroxine index and TSH, calcium and phosphorus, usually appear normal when you run exams unless there's some medical problem going on. Some of the abnormal lab tests that are more common in older people are listed. You got the SEV rate. It's a mild elevation, can just be related to age itself. So if you see a very mild elevation, it's kind of persistent, but there really anything else you can get your hands on, it might be just attributed to an age-related change. Glucose, you've been through that before. It always tends to go up when a person's sick. Anytime you have an infection, they just have less ability to maintain a normal range of blood sugar in a stress situation. Even if they, anxiety, a fall, a broken bone, an infection, a stressor where you might see a higher level of cortisol as a response to stress, you'll see a higher glucose level, and they don't regulate it as well. Creatinine can be slightly elevated, and I think y'all talked about, y'all did creatinine clearance calculations already, correct? And you know that that equation accounts for not only sex, gender, but also age and weight. And the age factor is kind of trying to standardize it against as a person gets older. That is, the older a person is, a lower creatinine may indicate less renal function than you might think. So if you have a 90-year-old with a serum creatinine of 1.2 and a 30-year-old with a serum creatinine of 1.2, who has the worst renal function? The old person by a lot. Okay, so when you're looking at those creatinine levels in older people, it's always a good idea to calculate a creatinine clearance just to get it in your brain. It has many implications for dosing medications that are renally eliminated, And so you might look and go, their renal function's pretty good. You kind of trick yourself, you don't know how far off it is. But I would say, a mid 80 to 90-year-old person with the creatinine of 1, their renal function is probably 30 or less, 30 mils per minute. That's basement. So just play around with the numbers, and it will surprise you, how far off people can be. Albumin is another one. I know you talked about albumin in other courses as kind of a measure of malnutrition, and that is one that you can look at in older people. So the albumin is one that looked at. It tends to decline a little bit because people tend to be a little less well-nourished the older they get. So that's one to look at. And honestly, they make the comment here about an acute illness. When a person is acutely ill, you can lose a lot of serum albumin fairly fast in people. So hospitalized, very sick people can become malnourished very quickly when they're older. So paying attention to nutrition and feeding is a big part of a critical illness in an older person than where it's expected to be long-term. There has to be thought given to food as well as hydration in that person. Okay, outphos, mild is not uncommon. If it's elevated, you're obviously going to rule out other diseases, liver diseases. What's a common reason for outphos to be elevated in an old person?
Osteoporosis.
Say it again. Gallbladder, did I hear that?
Osteoporosis.
Say it again, osteo. Yeah, well, you can have bone problems, and you can also have obstructive liver problems, and those are not that uncommon. And a lot of older people, if they still have their gallbladder, you kind of have to start worrying about stone in the duct or something going on with them. Again, it's kind of subtle, but it shows up with those lab tests. Serum iron, if the person's undernourished or bleeding, and you do have a lot of reasons for older people to have GI bleed because of medicines they're using, other problems, other medical problems they might have, it's not uncommon to see iron deficiency anemia and low serum iron and all the parameters that you would follow with them. But also undernutrition. So low iron is not that unusual. Even low red blood cell indices, all of those things. PSA, we'll let that go. That's been talked about in GE back in the day. Urinalysis, very often a person will be asymptomatic, and you can do a urinalysis, and that person will have some bacteria, but that bacteria may not be causing anything wrong with that person. But it can be significant and causing, cystitis in an individual. It's just not uncommon to see baseline, not clean urine in older people. Okay. Chest x-rays, interstitial changes are very common in older people. It's just part of being older without necessarily meaning anything more. Of course, x-rays, you also can see thin bones, pale, less density. And then EKG, consistent with your findings of not necessarily normal rhythm and rate all the time in older people, you'll see ST segment and T-wave changes, all kinds of different arrhythmias and even blocks that may be asymptomatic and may or may not need to be treated based on severity. Again, you start looking at how far down the road is a person and what you're going to do, what is your intervention, but often they're just parts of a failing physiology overall. Things don't work as snappy. AV node as healthy. Baroreceptors not as receptive and not as responsive. So you don't always have a situation that you are going to be able to treat, or the treatment may be too risky. You think about arrhythmias that you may want to treat. Think about your anti-arrhythmic medications. Were those benign medications for the most part? They're pretty doggone toxic. And in an older person, even more so. The percents are higher. So you have to think about what are you doing and what's the person want with an arrhythmia. Because what's the worst thing about an arrhythmia? Maybe it goes very malignant one day and you die. What if you're 91 years old and you have, AV node disease and you could have, shutdown. Okay, that might be the final event. Do you want to do pacing? Do you want to open them up? Do you want to put wires in there? Where are you going with that person? And I'm not trying to be fatalistic. I'm just saying at some point you have to start thinking about endpoints and what you're trying to accomplish. Okay. Any questions about your lab or your assessments just in regards to older people? I think it's pretty straightforward for what you've had before. Functional assessment, that little equation is just one that just kind of shows you the factors that go into it. We talked yesterday how functional assessment is very important in older people, not just what you need to detect on physical exam, but what can they actually do in their environment. That's a big piece of it. And you see function is physical capabilities, medical management of those physical capabilities, motivation, all divided by social, psychological, and physical environment. Those are all the variables that go into it. I don't think the equation mathematically makes a bunch of sense to me, but it just shows you what those elements are. Now, when you're doing geriatric functional assessment, you're always looking at it, point number one, you're always looking at it based on what is your purpose, what is the setting, and what is the timing. And the reason that's important is you have to decide where the person's going to be. Are you looking at a person who's going to be in the home and that's where they want to stay? In which case, functional assessment, there's more functions that we need to be able to do to be alone. If they're going to be in assisted living, maybe there's less functions they have to do because there's support for that. Or if they're in a nursing home, you then have to figure out what can they actually do because it dictates the level of care that person gets. Tomorrow we're going to talk about care environments, what do you have to do, and there's just a lot of rule and regulation about being in different environments and what assessments have to be done to be in that environment. So if you're assessing a person functionally, first thing you want to know is where is this person intending to remain? Where are they going to be? What are you trying to do? And every time a person goes into some facility other than their home, there will always be a full functional assessment to figure out where is it safe in that particular environment for that person. You usually want multiple disciplines to have input because you're looking at physical therapy. What can they do? How can they move? How do you improve it? Occupational therapy is hugely important when you're doing functional assessment for older people. How many of y'all have worked with OTs before? Has anybody worked with an OT? Talk a little bit about what they did, because occupational therapy is one of those things that a lot of times people aren't quite sure what all these folks do.
My experience is a little different with pediatrics because my nephew has special needs, and so the OT kind of figures out like where he is functionally and tries to teach him. Like they'll sit and practice eating. So it seems like really regular daily stuff that you would need help with, but when they have challenges, it's getting them to be able to do those little things that help them function.
Yeah, exactly. Jenna?
And the geriatrics, after surgery, just to make sure they're able to have a house where they have stairs they can get up and whatnot, or they'll have to learn rehab.
Yeah, just what is the environment they have to navigate and can they actually do that? And occupational therapy is everything from, utensils that are a little bit larger. If you have bad mobility in your hands, I mean, you can't really clutch. It's hard to pick up a fork. You have to kind of have fine abilities, and some people can't really get that. Or maybe they've had a stroke and they have a little bit of weakness, so you get the spoons and forks that are larger. Or they teach you how to do stuff like if you can't use your fingers to pick up a penny off of a table, okay, that requires some adjustment. Then they'll teach you how to do things like sweep it over into your hand. It's just different ways of doing stuff. You see those claws to pick things up. If your back is bad, you can't bend over, you can have that claw. My mother will, she's got a claw, but she hates to use it. And so everything in her place, I've kind of put it at mid-range, because if she's standing here, it's like, okay, in the little kitchen area, I've got the food to where it's all, top drawer, shelf, first drawer here, and then you start getting up to like the second and third shelf. It's hard to reach, and that's bad for her back. So I try to keep it all right here. And then we just use the high shelves for storage and stuff, and I kind of bring them down. Or I'll sometimes we'll see her bending over. It's like, no, don't do that. What are you doing? But it's just stuff like that to grab it, and think about dressing is really hard. if you've got arthritis or you have immobilities, just think about bending over and put your socks on or your stockings. Can't get down there, can't do that. So that's often a hard thing, getting shoes and socks on, pulling, shirts on and stuff. You have to kind of move yourself around. So there's different types of clothes you can get that will help you do. So occupational therapy is not just occupations, it's really daily living, things that you need to do. So you get other folks in there, part of your assessment. Assessments can be targeted. Initial screens are almost always done to even identify who all's needed. Okay, you can do a basic initial screen. Well, we need to bring in blah, blah, and blah, to look at that. We need a dietitian. We need a physical therapist. We need an occupational therapist to help assess this at a higher level. They're often done at times of threatened or actual decline in status. So at a hospital visit, when you had a major thing happen to that person, you kind of want that full assessment to figure out what abilities do they still have, what plans are we trying to make to get this person out of the hospital, can this person go home, or do they have to go somewhere else? And those are when it happens. So when big insults happen is when you need those assessments. Okay. There's lots of instruments available, and I don't want y'all to get all buried off into all the instruments. There's a few I do want you to know by name, but to be able to do all the items in them is not important at this point. That's more of a clinical phase learning when you get to that. But there's lots of instruments out there. Some are better than others. Some are validated, some are not. Some are very reliable, some are not. So there's just a whole bunch of tools out there. I think it's important to note in C and D is the discrepancies for what the instrument says a person does and what the person says and what an informant says, and then actually what they do. A patient can tell you what they will do at home. I can do this. They might even show you they can do it, but when they're at home they may never do it. And they may not do it for other reasons. They're depressed. They don't have interest. So you may go, yep, they can prepare food, they can do this, they can do that, but at home they actually don't do it. And if you have an informant, like a child of an older parent, they may not be around enough to actually talk about all of what that person can do. And sometimes they may actually want to overstate it because they want to give the parent what the parent wants to stay in the house. Yeah, she can do that, they can do that. And that may not be what they really do. They may be able to show a little bit of movement, but it's not something that will be sustained. So that's why the instruments are okay to apply, but it's even better to ask patients to show you what they can do and then to get that informed by those who actually know them daily, what goes on all the time. On the second page, we talk about open-ended versus closed-ended questions. Open-ended questions are okay when you have a lot of time for a big assessment, but in a short visit we talked about closed-ended questions just to kind of get it focused and down the road. So either one, depending on the situation. Okay. You do have to explore family expectations, capabilities, and willingness. Those are critical. And then the patient's preferences. Okay, definitions. Activities of daily living and instrumental activities of daily living. ADLs are self-care tasks that you learn in childhood. And I've got pictures of all like eating, bathing, dressing, transferring, getting up from a chair to a bed and vice versa, toileting, and walking or moving around. Those are ADLs, and you've heard those, and that'll be routine assessment on patients. What can they, what are their ADLs? And then instrumental activities of daily living are complex skills, and you see some of those like house cleaning, grocery shopping, managing medications, managing money. Those kinds of things are also required to live independently and not always easily done. Look on page 26. There's a little thing how to grade it. They're graded 3 ways. A person can either do a task without any human assistance. They're 100% able to do that by themselves. The second is they can perform it but with some human assistance needed. And then finally, inability to perform the task even with assistance. Again, that determines placement for people and major changes in life. It also dictates what services are given to people when they're in a location. Like, in the place where my mother stays, there's independent living section where people can choose apartments and they can have people cook and clean for them, but they can do it, they're just choosing not to tax their body that way. And then assisted living is when there's some requirement for help. May not be 100%, it's certainly not nursing home, but if you need help, you can get it. Like, my mother cannot get stockings on and she wants her stockings on. So, you know, a person comes in, helps her get them started, and helps her get stockings off. They manage medicines. It was kind of a debate. They will either do it or not. You can do a functional assessment and then we'll decide what to do. And they eventually asked us what we thought, and I said I thought it was a better idea if they kept track of them and she kept track of them, for all the reasons we'd already seen. She kind of argued with me, and I said, you know, I think it will just be easier not to have to worry about it, and they'll keep track of it. And so that has actually proved out to be pretty good, with some exception of kind of fussing about what they do. Because you have people in those facilities that they are not highly educated, and some of them are a whole lot better than others, and we have caught mistakes. And when she is still completely tuned in, she'll pick up their mistakes, and then she'll say, I don't trust what they're doing. And I'll go, tell me. So I'll tell the chief of nursing what we're seeing, understanding what limits they've got, you know, to do it. So it's been a thing. So there's that. Preparing food, cleaning, making a bed. I mean, it's hard to make a bed if you can't really move around and do stuff. So those things get assessed in placements. The table just lists out what the picture showed, activities of daily living, and then the instrumental activities of daily living, which we talked about. Now, the assessment tools are used. There are several. Some of them will throw off. You don't need to worry about the Marfell index at the bottom 26. You just mark it off. I don't care about it. I do care about the CATS and the Lawton. The CATS on the next page, 27, the CATS index is evaluation of independence in the basic ADL. So it's just looking at ADL, not instrumental activities of daily living, just ADLs. So it looks at it, it evaluates that and gives a marker of how independent a person is doing those. The Lawton assesses the ability to perform 8 independent activities of daily living. And they're listed, I don't care if you remember the list, I just want you to know that CATS is for ADLs and Lawton is for IADLs. Okay? But it looks at things like telephone use. Isn't that interesting? Most older people don't do cell phones. At a certain point, they don't do phones. My mother has a pickup phone. I said, I will get you a cell phone. I have tried to show her iPad, and it just is not something they want to do. I don't know. I wish they would. It would be easier to do. But she just has the phone. You pick it up, push the button, it answers, and then put it back down. Flat cell phones, touching. I think actually the screens are harder for older people to navigate, to hold push buttons and to kind of get it just so. And you know how fast we are doing phones? They're very slow. It's like, oh, hit that. It doesn't quite happen. So I want you to know those two. And then you don't have to worry about the FIM. I'm not worried about the FIM. But 5 and 6, you do need to know what they are and where they're used. The MDS ADL, that is required for all residents who go into a CMS certified nursing home. That has to be filled out, scored, and reported to the government. Okay? So that's the minimum data set for activities of daily living. And it does determine how much support is needed. And as every government agency would have it, it gives a number and then it dictates what cost of things you can get. It just prices it all out. You get a nurse, you can get whatever. And then the other one, OASIS, as Outcome and Assessment Information Set, Functional Assessment, that's required for all CMS certified home care agencies. You have to know what the person can do in their area with a basic and instrumental IADLs. And again, there has to be a certain score so that you can get home care. If you don't fail enough, you can't get home care. y'all are just moving into the whole world of acronyms and government and what you can get and what you can't get. But you will all navigate it beautifully. And by the time you've learned all of it, you can be assured that come January 1st of every year, they'll change something else. It'll be a different thing. Taylor, you're shaking your head. Is it true?
Yeah.
It is. The worst time in healthcare, I think, is January, because in pharmacies, I know Kristen will shake her head, all the insurance plans change. And it's not just medicines, it's everything. Co-payments, services, it's just so crazy. And you really don't know what you got until you kind of have to start getting. And they'll say, please review your care and cover so you'll know how to respond. And I thought, I don't have time to read a 100-page manual, which is what they are. They ship you all this stuff and you go, oh my gosh. I just follow. My mother says, do you know all we can get this in? We'll figure it out when we need it. You're not going to read it all. All right. Another measure is gait speed. Okay, and on Wednesday afternoon, Maria Jones is going to talk to you all about gait, posture, and fall risk, and she'll talk about gait. But gait speed is a marker of functionality and also predictive of how a person will turn out over time. You can just clock how fast somebody can move. So you'll see the little picture at the bottom, there's an acceleration zone where they clock you during that 4 or 10 meters section, okay? And then there's the deceleration zone. And they usually, the times I'm going to give you are based on a 4-meter distance. If a person is 1 meter per second, then that suggests intact mobility, means they can move on at a pretty good pace. When they get to 0.6 to 0.1, they become high risk, and anybody less than 0.6 already has functional difficulties. So that's part of the classification schema of prognosis, is how fast you can walk. And I think you can tell from your own basic awareness is watching people. When a person cannot walk very fast, there's many things they cannot do. And that not walking fast usually has to do with neurologic and or musculoskeletal problems, which will not be limited to the lower body. It will be upper body and other movements that need to go with that. Okay, why don't we take a break? Go run around for about 10 to 15